Hello, welcome to another episode of Executive Suite. I'm your host, Thomas Braun, and today I'm here with Kevin Williams, the CEO and co-founder of Ravel Health, which is on a mission to help Americans with their chronic conditions, health conditions, and has a huge potential. And we're going to talk to him about what the company does, and then we're going to pivot over to scaling up a tech company in the healthcare space. So Kevin, please start us off with a description of Ravel Health and what your mission is.
Thank you for having me on. As you mentioned, Ravel provides virtual care to what we call complex chronic illness patients with things like Lyme disease, and co-infections, mold toxin illness, long COVID, MECF fatigue syndrome, fibromyalgia, and things of that nature. Happy to about how we came to be and what sort of instigated creating this company.
Yeah.
So back in, let's see, it was 2007. I was probably, in the best shape of my life. Was very active. Had just finished doing a half marathon. Was playing a ton of sports, and then all of a sudden, just started getting this weird constellation of symptoms that start popping up. Started with cramping in my hands and feet, and then that moved into my sort of that migratory cramping, which looking back is very indicative of Lyme disease, but I had no idea at the time. I started noticing playing sports quite a bit where I didn't catch my breath. I was just really tired, and symptoms sort of progressed from there. Started getting a lot of GI symptoms after that, a lot of nausea, bloating, things of that nature. From there, I moved into um, more, neurodegenerative type symptoms. A lot of brain fog, a lot of dizziness, eye issues, memory issues, and it sort of was a gradual build from kind of slow burn for me over the course of a couple of years. Around 2012, I got to a point where I did walking. I actually had to think about it. I thought I had MS at the time, and then for whatever reason, my symptoms just sort of plateaued. Around 2012, 2013. Like most patients, in this space, my primary care physician had no idea what was going on. Most of the specialists, they view things, specifically through their own lens. They had no idea what was going on. And was just sort of pushed from one specialist to another over the next, 5 years or so. In probably 2015, I got on a wait list with a well-known doctor in Colorado, which is where I was living. She actually had a wait list of 2+ years, which seems sort of silly to me at the time. I figured I would be better, by 2000. Of course, that time rolled around and still had all these issues going on. In the years in between, I would go on fits and start trying to see as many providers as possible, but get nowhere, get disillusioned, start up again. Got a provider in 2017. I got the Lyme diagnosis, and come to find out, that's really only half the battle with a lot of these conditions. So at that point, started working with a number of providers on different protocols to try and get better. It was a lot of one step forward, two back. It was incredibly expensive. Just a lot of obstacles for this particular patient. Forward to uh, you know 2019, the frustration had sort of built up to a point where I really actually wanted to do something about it. I wanted the last decade plus to really count for something. And that's where sort of the initial idea Ravel was born. And then I met my founder Jamie and Tilly in summer of 21, I think it was. And then we ended up launching um, our pilot in Colorado in October of 23. And happy to get into the weeds on what that process looked like, how everything works, whatever it might be, dear listeners.
Okay. So what you're trying to do is fulfill some kind of unmet need here that you've found for people starting with Lyme disease, but on your website you list a number of other chronic conditions. So describe to me, let's say I'm a patient who thinks they might have Lyme disease or doesn't know for sure. I don't know if there's a diagnostic test yet for is there?
There are a number of diagnostic tests. The jury is out on how effective they are. You can talk to 10 different providers in space, and they would tell you certain labs and certain tests are very good and very accurate. Half of the providers would say that the testing, is not overly helpful, which
Okay.
makes it, that's, another piece that makes things really challenging. There's
Okay.
not one definitive diagnostic, really.
So when people come to you, they think they have something, and then they subscribe for your services, and so they have to do that because, correct me if I'm wrong, they have to do that because their current healthcare providers, their family doctor or whatever, has no idea. Is that it?
That's usually the case. I mean, depending on where someone lives, if they're in the Northeast, in the United States, primary care physicians usually typically at least know about Lyme. Doesn't mean they're necessarily literate in it. Many other places in the country, doctors don't know how to treat it, don't know that it exists, even chronic Lyme. One of the silver linings of COVID is that, you have all these patients now with, tens of millions of patients. Mainstream medicine can't say that these, post acute infection, chronic infections don't exist anymore. Now that these patients. So that's one of the big issues is to try to, for patients to find a provider who, understands what they're going through, where they're not going to medically gaslight the patient, and where they know how to help, help a patient. That's one of the big things that we do is we curate and vet all of our providers, and do all of that initial upfront work and make sure that, all of our providers have 6 years of experience treating Lyme currently, and other complex chronic illness. So we take care of that, piece for the patient. When someone is, you know, dealing with all these symptoms and at their worst, the last thing, they want to do a lot of times is try to, find someone who actually who knows how to work with them. And, they have to do that whole vetting process. So we take care of that piece for them.
Okay, so they're talking to a medical doctor online. Is that it? So you have remote, like Zoom, as it's like a Zoom call with a doctor.
Correct. Everything is virtual. The way we set it up is patients would come to our website. It's just ravel.health. We have a get started button on the homepage. Once they do that, we have patients, create an account patient portal. It takes less than a minute. From there, we have all of our patients fill out a virtual patient questionnaire. It's about 10 questions, talks about their, health, current symptomology, if they've done any previous testing, and then we ask what their treatment philosophy is. So if they prefer more conventional, more herbals and homeopathics and that sort of thing, or more of an integrative approach. And then based off of that, we'll match patients with up to 3 complex chronic illness literate providers based off the answers to their questionnaire and the state in which they live. And then we send the patients the provider profiles. They'll look through that, let us know who they think the best fit is. If they have questions, offer discovery calls with myself and my co-founder, and also with the providers. One thing in space, it's very difficult for patients to talk to a provider typically before they start working with them, which is kind of crazy because usually, an initial appointment, this is all very different than, how medicine is typically approached in the United States. Most times patients have, 9 to 15 minutes with a doctor. In this patient population,
Yeah, if
usually
you're
that,
lucky.
if you're lucky, right?
Yeah, after waiting an hour in their waiting room.
Exactly.
And
So,
some of them they'll
so
have they have a sign up on their wall in the treatment room saying that they'll only talk to you about one thing at a time. So if you've got one of these chronic diseases that's causing you like 5 different symptoms, like, oh, I have digestion problems and I have, nerve pain or joint pain and or headaches, or like, how do they do that? Like, oh no, you told me about your headache. Now we can't talk about anything else. So it doesn't work.
yeah, I mean, exactly. So you hit the nail on the head. I mean, all these conditions, that we've touched on are multi-systemic. There's a lot, they're very complex. So, to try to, think that you can get to the bottom of something in that, a short amount of time is
Yeah.
crazy. So, so we do, 2-hour initial appointments. That's not uncommon with this patient
Hmm.
population. But a lot of times, patients are expected to do that 2-hour appointment without being able to talk to the provider. So we offer discovery calls with our providers as well. It's they're 15-minute calls. It's $45 per call. And we encourage patients to talk to the provider, to get insight into how, they might approach their care. And then if they want to move forward, we apply that $45 to the initial patient visit. So as mentioned, that's a 2-hour visit, prep and post work time that our providers put in. And we charge $395 for that, which is, a big part of our mission is to be as affordable as possible.
Yeah, that sounds pretty cheap. Because usually doctors are like $400 or $500 an hour.
Right, right. So it's not uncommon for that initial visit to be well over $1,000, for patients, and then follow up
But not with you, with other people.
with other people, right? With follow up to be, like, as you mentioned, $500 to $700 an hour. So yeah, we're $395 for that first visit, and then we're a monthly subscription. We're big believers in continuity of care, especially with these conditions. There are a lot of triggers that can cause people to flare. And oftentimes, in other clinics, and this has been, my experience and the co-founder's experience, if you're needing to see someone, even if you're a current patient, you often can't get in for, 2, 3 months. So we wanted to make sure monthly check-ins. The way we do that, we try to be really flexible for patients. We have 30-minute, 60-minute, and 90-minute appointment options monthly, and patients can upgrade and downgrade um, based on where they are. And for 30 minutes, it's 115. For 60 minutes, it's 215. And for 90 minutes, 305.
Yeah. Now, I'm just wondering, is there a licensing issue with this kind of remote medicine? Like, does it matter if the doctor is in Nevada and the patient's in New Jersey?
So there are the regulatory framework. I'm not sure exactly how it works in Canada. It's very fragmented and challenging, stateside. So in your example, the provider could be in Nevada, and the patient in, I forget what state you said, but so they can live in different places, but essentially the provider needs to be licensed in the state in which they're providing services. There are caveats to that as well. There are things depending on designation. So we have, MDs who work with us. We have NPs, nurse practitioners, and we have NDs, naturopathic doctors. There are certain things, just as an example for the MPs, there's something called the Nurse Licensure Compact, which is essentially, reciprocal licensure where nurses can work in other compact states. But in those states, if they're not fully licensed there under the compact, they do have a more limited scope of medicine. So there are all sorts of different rules and regulations depending on the provider type, MD, NP, or
Hmm.
ND,
Hmm.
and then also the states in which they're providing services in. But essentially, they need to be able to legally provide services that the patient resides
Wow. Okay. So that adds a bit of a complication. Puts people in small states at a bit of a disadvantage, though, doesn't it? I mean, like if you're from California or Texas or Florida, there's going to be tons of doctors for you to access, I suppose. But for somebody who's from North Dakota or Nebraska, maybe they don't have a Lyme disease specialist in their whole state. If there's, there might not be in North Dakota. So what do you do then?
And that's very much the case. So, those states that, have smaller populations are more rural. They don't have the same number of experienced providers. And depending on where you're at, you mentioned California, right? So California, there are a number of providers in California, but they're extremely, by and large, they're extremely expensive. So,
Mm,
where we come in sort of on both fronts is that we just added California's challenging on the regulatory front. See, we just added California to the states that we serve just a month or so ago. So we're in 47 states now. We're still working on the last three. But, in California, for example, we're able to provide a much more option to patients than in states like North Dakota or Montana or some of these other states where there's not as many providers. Our providers can still legally work and provide services in those states. So it's a really nice way to, for patients to access services where they don't have to travel for hours and hours, potentially go to another state to see someone they can actually get help from, the comfort of their own home.
yeah. Well, something that came out of COVID is, a real boom for remote healthcare providing because a lot of insurance companies didn't allow doctors to talk on the phone. I can tell you here where I live in Vancouver, insurance wouldn't pay for doctors to talk to people on the phone. So they would just refuse. Like even if you phone their practice or you have an emergency or whatever, the nurse will just say, go to the emergency ward. So then during COVID, because of the social distancing, I mean, which we now know turns out didn't actually do anything, but at the time nobody knew, I guess. So we were forced into the social distancing and the lockdowns, and so they moved to these remote operations. Now, my family doctor, you can't even get an appointment to see him. It's a telephone only, and then there's like a wait. If you talk to him on the telephone, you can get in pretty quickly. If you want a Zoom call, then you have to wait a bit. And if you want an in person meeting because you want them to look at something, then forget it. It's not going to happen, or it's going to be way in the future. So he's gone completely remote, and it works pretty well. It's pretty convenient because he'll call me up on my cell phone if I need to talk to him, and 80-90% of these doctor visits to the family doctor, it's just to renew a prescription or to get a referral to a specialist. And he can do that over the phone very easily. And so it makes it easy for me. It makes it easy for him. The whole thing takes 5 minutes, and it's just so convenient. But it really makes me wonder how we could have been so backwards for so long, and why did it take this pandemic in order to switch the light bulb on? Like, we could have been doing this for years, because the internet started in 1993, but we didn't start with these remote medical visits till post COVID. I mean, some people, maybe private providers like yourself, where people are paying out of their own pocket or something, might have been doing it here and there. But for the most part, it just wasn't covered by insurance. This raises an interesting issue, which is, are your services covered by insurance?
They are not. So we are cash pay almost entirely across the board. The only thing that we actually do default and run through insurance is standard lab testing. So things, done through LabCorp requests, we default to patient's private insurance. But outside of that, everything is, and even like with Medicare, Medicaid patients, we work with patients, but we're not legally able to bill anything through Medicare, Medicaid. So that's all cash pay as well. So
Hmm.
we do provide super bills upon request for patients to submit to their insurance. But
Sure.
everything else
If
is
they have like
cash.
some kind of a nice employer provided plan that covers extra things. This is a bit of an aside, and it's a little bit off our topic, but you did mention the Northeast, and that doctors there know a little bit more about Lyme disease. So that's where it originated, is what I understand, in one of these states in the Northeast. Do you know about the
Correct.
origin story of Lyme disease?
It actually originated in Lyme, Connecticut, hence the name.
Oh, okay.
I'd have to refresh on the particulars, but there were a number of, I believe it was children who, had similar symptoms. And yeah, I forget, as I said, I forget the particular. I think, at that point it was sort of dubbed, Lyme and this disease. I believe that
Okay.
was in the, early to mid 70s. And then, interesting, it's been almost, what is that, 50 years where you've almost, in many ways gone backward on, Lyme complex, chronic conditions. And most of that, I think, is because of what we're talking about, right? Where, sort of the mainstream medicine, how it's set up is not, able to really create these diseases. And,
Well,
same
that
thing
would
with insurance.
change. Listen, that would change overnight if Pfizer had a vaccine for it. I can tell you that much. Make it mandatory. Everybody has to have their Lyme disease vaccine. So I
Well,
think
I know. So
the
it's
problems
actually,
is that big pharma doesn't have a drug for it. Maybe that's the problem.
well, I think so. A couple things there. They did actually have a vaccine that came out in, I think it was like mid to late 90s, that people started taking, similar to some of the COVID vaccines, right? Where you have some of these vaccine injuries that were reported, sometimes more harm than good being done,
Hmm.
and a lot of negative backlash in the press, and it was actually pulled from the market. And there are clinical trials underway. I think they're in phase 2 or phase 3 with their potential vaccine. I mean, I think there's a couple out there that act a little bit differently on the Lyme front. So we'll see kind of where those end up and how they progress.
Now, I read something recently about the origin of Lyme, and I was wondering if it's just complete nonsense, or if there's any truth to it. But that there was like
I
a
think say that, yeah.
yeah, it came out. Some people think it came out of a research lab, and that in the 1960s, infected ticks were being dropped on farmers' fields in Cuba as sort of an anti-Cuba campaign. And so they thought, if they can, maybe they can starve the communists or something like that. So, which was part of the game back then. That was part of the strategy. And you see, in Vietnam, they sprayed napalm over all of the farmers' fields. They just thought, well, maybe we can starve these people. So, is there any truth to that? Do you think? Do you know anything about that?
Yeah, I've heard similar stories that it was initially created bioweapon.
Hmm.
There's an author, I believe her name is Chris Newby, who actually has a book that she wrote on this very subject. I haven't read the book. I haven't spent full transparency really any time at all, kind of researching the possibility of that.
Hmm.
Our focus is more on, knowing it exists and, how do we find better markers to, determine who actually has one versus some of these other complex chronic illnesses because there's um, so much symptomology overlap and overlap in how it manifests. And then how do we try and make people better and figure out,
Yeah.
each person's different, they react differently. What do those protocols look like? So yeah, I mean, I've definitely heard of that. I'm not sure as to the veracity of it.
But so right now, nobody really knows for sure where it came from. It just spontaneously appeared in Connecticut in the 1970s. And that's all we know.
I don't think it spontaneously appeared per se. I think it was in existence prior to that. It was just
Yeah.
sort of given a name at that point.
Yeah. So anyway, I just saw that in the news. I thought I'd bounce it off you to see. Let's pivot and talk about how you're going to scale the business. Okay. So we spent the first half of the interview here talking about the service you're offering in Lyme disease as sort of a kind of a lead application. But I'm curious, how do you plan on scaling the business? Because there must be hundreds of thousands of people with Lyme disease in the United States. Do you have any idea how big the market is?
Yeah, so for chronic Lyme, most of the numbers, and these are, CDC numbers, so I would take them with a grain of salt, are probably low estimates. But CDC probably looking at between 2.5 and 3 million chronic Lyme patients. Again, that number is probably quite a bit higher.
Hmm.
The CDC right now probably be going up pretty soon here. They have listed 476,000 new cases of Lyme here. So that's just Lyme. And then if I mentioned long COVID,
Hmm.
just in the United States alone, on whose stats you look at, it's anywhere from, 15 to 20 million people with long COVID. I've seen between 20 and 30 million. Again, that's the US alone. And then if you bring in, some of these other conditions like chronic fatigue, fibromyalgia, things of that nature, collectively, you're looking at probably 50 million plus in the US for these complex chronic illnesses.
Now, did you say 50 or 15?
50, so 50.
Wow. Wow. So that's a lot. That's like 1 in 6, 1 in 7 people walking around with one of these chronic illnesses. So how are you reaching out to them and marketing this service to them?
So to this point, we've really only been talking to the Lyme community, probably a good year and a half at least prior to, officially launching our pilot, talking to as many providers and organizations in the space as possible. So we have, a number of partnerships in place. So we, do some marketing through them. We do some things through social. We've been on a handful of podcasts, like this,
Hmm.
speaking about Ravel and the company and, what our aim is and our mission. We had some articles done at LymeDisease.org. So it's one of those communities. It's a pretty tight knit community in that, people who are going through this, they call themselves Lyme warriors, can be a debilitating condition, and I think um, there's a shared experience there. And so, when you start to get the word out a little bit in the space, there are always people, in, forums and on social and, whatnot, talking to each other and spreading the word. So we've really been focused on, trying to get, service dialed in as best as we can here, and we're continually making improvements. And then, we've actually done pretty minimal marketing to this point, with very little paid marketing, but again, it's a tight knit community, and the outreach avenues are pretty clear. So we've been doing that, but want to start spreading the word even more here.
Yeah. What kind of partnerships are there? Patient associations?
There are some patient associations. So, I mentioned LymeDisease.org. They have a patient. went to, I guess they're, patient association, and they have a patient database essentially. So where patients can volunteer, information on their condition. I think they were at slightly over 17,000 participants last time I checked. And then we partner with, Global Lyme Alliance, for example. They're, a big leader in the space.
Okay, but
We do have them.
how do they help you, these partnerships? Because like my experience is that they'll say, well, we're a nonprofit and we don't choose one provider over another and we can't recommend you and no, we can't give you our lists. And so my experience is that a lot of these organizations, they're actually not very helpful at all when it comes to trying to communicate like new technologies or whatever to the patients. And they just kind of exist to raise money for themselves basically. And like I used to run a skin cancer company, and you try and you know get the skin cancer diagnostic, and you try and get some cooperation from them, and all they really would want from me is a donation. And they say, oh, your company can donate money to our nonprofit. And it's kind of like, well, we're a startup company with no money, but we have a diagnostic that can save people's lives. And as soon as they hear that you're not going to make a donation, they sort of shut down, right? So that was my experience. So are you getting any real help from any of these groups that claim to be patient advocacy groups, or charities that are raising money for research?
Yeah, I mean, it's, I think early on, so the Lyme disease, for example, they'll do, quite a few articles. They have stuff that comes out weekly. In our early days, I think they were waiting to see, what the feedback was on what we were doing, like the direction we were going. So there wasn't necessarily that assistance per se, in the early days. But they cover all sorts of things. So, at one point we onboarded, really well-known chief medical officer. We brought him on in April, I think. And so, rather that lended, instant credibility to what we were doing. And, they did a couple stories on us there. So that was very helpful. And like Global Lyme Alliance, for example, they have a lot of these organizations. They do have provider lists, so it's not not like they're referring specifically to us, but we're just one of the options that they'll relay to patients,
Hmm.
when they're like instance. And then we worked with other organizations too, where they just help us with if maybe in their newsletter or blurb on social. So it's been baby steps to this point primarily, but I think because at least in this space, patient and providers, researchers have been cast aside for so long that I've been really sort of humbled by the response that we've had thus far. I think there's a feeling that we're all in it together. It takes a village to try to bring light to a lot of these conditions and actually create some change. So I think that's helped and maybe made it a little bit different than some other areas of care.
Yeah, it sounds like it. So more of a genuine community, and as opposed to, people who are just trying to make money. Because the one of the things that was kind of a wake up call for me when I got into the medical device business was how, money guides everything with medicine and with doctors too. Like like if you ask them, they'll say, "Oh, I became a doctor because I wanted to help people." But the reality is that the dollars and cents are all that matters to hospitals, doctors, the insurance companies, the drug companies. All their decisions are basically motivated by money. And so if there's nothing in it for them, then they won't do it. And they don't care about the patient. I mean, that was sort of the eye opener for me, because I kind of thought that people were a little bit more benevolent, that there was sort of like a good Samaritan in there somewhere. And I was sort of surprised to find out that they're not that benevolent after all. So anyway,
And that, I mean, that's basically why we try to work outside of pretty much all of those, institutions that you mentioned, as
yeah.
much as we can. The providers who work for us, they have to have that compassion because
Hmm.
what we're charging patients and what they could make elsewhere doing what they do. Um, they have to have, I think, that desire to really want to work with these patients and want to help them.
Yeah.
You don't necessarily find elsewhere.
Well, you are making it more affordable for the provider as well. Okay. Because if they can move entirely remote, They just need to have a home office. Okay. So you just got rid of half of your expenses. Like, because so normally for a medical office, about 50% of their income goes to pay for overhead. And that's like their rent and the receptionist and, all the other people they have, office manager, whatever. So if they can cut all of that out, it makes it a lot cheaper for them too. Even though they might be in their office, they're trying to generate $400 or $500 an hour of revenue. That doesn't go to them. Half of it goes to their overhead. So they're really only making $200 an hour, which is kind of, more in your ballpark, I guess, based on your
Right.
initial visit. And then the follow-ups and all that. So I think that it's and if they can eliminate the travel time and having to go into an office and find parking and all that other stuff, so much easier, of course, to just go into your home office, you switch on your computer and you can start making money.
Yeah, I mean I'm glad you brought that up because we, both my co-founder and I are, long-term chronic patients. So we, came at it initially from that perspective, but we wanted it to be as convenient and streamlined for the provider as well. And as you mentioned, yeah, so if they don't have to have a brick and mortar, that saves them, a ton of they can be completely flexible on, when they schedule with appointments, how many hours a week that they want to work. We just make sure if they're matched with a patient that they have enough time in their calendar to provide services to that patient. And then we provide all the wraparound services, to the provider with the idea being that, the provider focuses on what they do best, and that's, working with the patient. We take care of all of the, all the that I think can be frustrating to a lot of providers, as far as, billing and collections and
Oh
you know,
yeah, that's a huge help.
having all that, yeah. So all that stuff. So that's sort of the idea is we provide, everything they need so they can focus on doing what they do best.
Yeah. And also, if you're working remotely, then you can live anywhere you want. You don't have to live next to the high population center where the cost of living is higher. You could move out a bit farther because you're not commuting. And, even if you have kids, as long as there's an elementary school close by, you're fine, right? Like, so if you lived in California, you could decide, well, instead of living around San Francisco or Los Angeles, maybe you want to live in Lake Tahoe, and you can buy a really nice house there for $600,000 or $700,000. Same house in San Francisco would be millions, right? So you're not
So
killing yourself just to pay a mortgage and inflated property taxes. So I think it's really good for the providers as well. I think so. Yeah. So what are your plans? Let me just, before we wrap this up, let me just ask you, okay, you've started this very recently. You're just getting going. You're working on automations and that sort of thing to help streamline your process. But what is your plan for like the next year? Are you planning on a rapid scaling up? Are you going to be making a big effort there, or do you just want to grow this slowly, organically? What are your plans?
So we're looking to scale up relatively quickly. We're in the midst of a raise right now that will allow us to bring in some reinforcements, as you mentioned, automate all the processes that we're doing manually currently. So we did that purposely to start. We didn't want to get locked into something and then find that that wasn't we could do it. We have, a ton of feedback from both the patients and the providers now that we've incorporated into, our onboarding and things of that nature. So the idea is to automate a lot of that, build out our platform, bring in, most likely a virtual office manager, really start to hit the marketing here, toward the end of this year and into 2026. As we scale, we have 8 providers currently, including our chief medical officer, what we call an over who's licensed in all 50 states. So he allows us to have prescription support nationwide, which was really big for big requests our patients had. And so that was probably a couple months ago. Um, so even with the minimal amount of marketing, we have more patients coming in than Jamie and I almost to this point handle where we're essentially spending all of our days running the clinic where we'd rather be focused on, okay, how do we grow and build and scale.
Hmm.
So that's where some of this help will come in, and then once we get those pieces in place, I think we'll be able to expand a little more quickly That'll include adding more providers. And so we have, a vetting process curation vetting process for all the providers. We have them do, final interviews with our chief medical officer. And so, as we get more providers in place, as we, again, we're at 47 states right now, after we get the last 3 states added to really just start, kind of building patient panels and expanding there and expanding services. We're about to launch here pretty soon an acute tick bite package. We want to create a framework for our providers to work. That's our patients have an idea of sort of the, kind of overarching that they would go through to get better. And then, from there we want to expand internationally. So there's a lot on the roadmap. There are a lot of things we really want to do. So that's the quick hit version of the next 6 to 12 months.
Do you have a lot of competition right now? I didn't really see any.
Not much. No, there is one company launched recently that focuses specifically on mold toxicity and one
Right.
specific sort of approach to mold toxicity. But outside of that, there's some other companies that just touch on chronic illness high level, but we really haven't seen many people trying to do the complex chronic illness space. I think just because it is so challenging and difficult with how much is going.
But yeah, that mold thing is very interesting. It's not the mold itself; it's the toxins that it produces, as I understand it, and a lot of it comes from building materials that have antifungal chemicals built into them, and the mold is trying to defend itself by producing these toxins. So in nature, when the mold's on a plant and the plants have the ability to create chemicals to attack the mold, and then the mold has the ability to fight back and try and kill the plant. And those toxins are harming people. Encourage people to learn more about it, especially if you think you do have mold in your house. But we'll have to wrap it up now. And thank you so much for coming on and sharing with us. And I wish you the best of luck with Ravel Health. And if people want to know more about it, the website is ravel.health. So the extension is health, not .com, ravel.health. And you can go and see what they have to offer. Thanks again for coming on. It
Thanks again for having me. Really appreciate it.
was my pleasure. Bye for now.